This conference will now be recorded.
So we will start now. So today I'm discussing this April talk, 2017 April talk, that is management of endometriosis related pelvic pain. Now remember, these recommendations are only for pain and not for other symptoms of endometriosis like infertility or anything. Okay, so that you should remember first. And another thing that you should remember is new ICHRI guidelines 2018 has come up, but I think all the recommendations are almost same. They have not changed much. So this talk is very good for management of endometriosis, all both medical and surgical. But remember that it is only for pain. Okay, so it is not for infertility. So what is the definition of endometriosis? It is the presence of endometrial glands and stroma in ectopic sites outside the uterus. Surgical and clinical manifestation, they both vary and they don't have any correlation. So surgical stage and clinical manifestation, be it a pain, be it infertility, they are usually not correlated to each other. So surgery, you may find very serious disease, the patient may not have any problems, or with just minimal or mild endometriosis, also patient will have severe pain. So these are not correlating to each other. Another thing is etiology and pathogenesis of this endometriosis. It is multifactorial, okay, and it is very elusive. So this endometriosis, it can progress, it can remain static, or it can even regress. And we don't know exactly with which treatment it will remain or become aggressive, or it will regress. So management remains controversial always. Now, what is the mechanism of endometriosis related pain? So it is thought to be, it's a peritoneal inflammation with involving growth factors and cytokine production by activated macrophages, which will also cause adhesion formation and irritation or direct invasion of pelvic floor nerves by infiltrating endometriotic implants. So it may be because of cytokine production, it may be because of adhesion formation, or it may be because of nerve infiltration. So all these things can be responsible for endometriosis related pain. So remember these three. One is cytokine production, another is adhesion formation, and third is peritoneal irritation, and fourth is nerve infiltration. So these are the 3 or 4 mechanisms which are responsible for endometriosis related pain. Now, what is the prevalence of endometriosis and what are the different types of endometriosis? So endometriosis prevalence is generally it is 6 to 10% of women of reproductive age. And when the patient is complaining of pain or infertility, so in those women, the prevalence may be as high as 35 to 50%. So generalized prevalence is 6 to 10%, but when the patient is having this dysmenorrhea or subfertility, the prevalence may be as high 35 to 50%. Now there are three types of endometriosis. One is peritoneal endometriosis, another is ovarian endometriosis, and third one is deep infiltrating endometriosis. Peritoneal endometriosis means it is a minimal or mild endometriosis. Here there will be no progression usually. Okay, so peritoneal endometriosis is just involving peritoneal implants, small peritoneal implants. It is usually minimal and mild and no progression. Ovarian endometriosis, might be superficial ovarian implants or endometriotic cyst, which can be adherent to posterior aspect of broad ligament. So it may also produce adhesion, or it can be just superficial implants, or it can be endometriotic cyst. Now, the most dangerous part is deep infiltrating endometriosis, which is also known as DIE. So deep infiltrating endometriosis, it usually involves other organs than the uterus. So usually it involves bowel, bladder, rectovaginal septum, and it is usually associated with very deep pain and pelvic adhesions. And it is very difficult to resect also. What are the signs and symptoms of endometriosis? So the most common patient we will usually present with dysmenorrhea, chronic pelvic pain, deep dyspareunia, dyschezia. Dyschezia means painful or difficult defecation, and subfertility or infertility. Now when the patient is having this dyschezia and deep dyspareunia, these are usually suggestive of deep infiltrating endometriosis. Dyschezia and deep dyspareunia are usually suggestive of deep infiltrating endometriosis. And as I previously have said, there is no relationship between pain and stage of disease. So pain intensity does not correspond to the spread or stage of the disease. Okay, and usually it has been observed that there is significant delay between onset of the symptoms and definitive diagnosis. So definitive diagnosis and so from onset of disease up to diagnosis, so delay can be as high as 6 years, 8 years, or 11 years or so. Differential diagnosis for endometriosis, it includes pelvic inflammatory disease, pelvic adhesions, irritable bowel syndrome, inflammatory bowel disease, interstitial cystitis, and depression. So psychological, psychosomatic disorders. So how you're going to diagnose it? So depending upon the examination and investigation. So now what should be the strategy for diagnosis of endometriosis? So usually this routine vaginal examination is insufficient to make the diagnosis. Okay. So how we should proceed for diagnosis of endometriosis? So first it is suspected on the basis of history. As I told you, depending on the symptoms like dysmenorrhea, dyspareunia, dyschezia, subfertility. So all are symptoms. And when the patient history is suggestive of this endometriosis, then it should be investigated by physical examination and imaging. So in physical examination, you may find some adnexal mass, you may find uterosacral nodules on vaginal examination. So depending upon this physical examination and then imaging. Imaging means ultrasound, that is transvaginal ultrasound, is also a good tool for diagnosis of this endometriosis, but and also if required MRI. But the final diagnosis, it will be by visual inspection and histological examination of the excised tissue. So the final diagnosis of endometriosis is during laparoscopy. Okay, because you have to do the visual inspection and it is not possible by any other method. So laparoscopy is the definitive diagnostic, okay, for endometriosis. So whenever the patient, whenever you want to give diagnosis to the patient, because as I told you, the definitive diagnosis is by laparoscopy. So patient should be always counseled about alternative strategies. Like as a laparoscopy is an invasive procedure, always you should counsel the patient regarding there are empirical managements like hormonal therapies and NSAIDs, which you can use before a definitive diagnosis, or you can directly go for see and treat laparoscopy. Now, once the diagnosis is confirmed by laparoscopy, then for this pain, the choice is medical or surgical management. So now we will come to this management option. What are the medical options available and what is the surgical treatment for this endometriosis? But before this thing, definitely you can try empirical therapies, okay, before laparoscopy. So now regarding medical treatment, analgesics. So NSAIDs, they can be effective analgesics because it can also treat simple dysmenorrhea also and adenomyosis also, but they are not specific for the treatment of endometriosis. So NSAIDs may be useful for this dysmenorrhea or deep pelvic pain, but it is not a specific treatment for endometriosis. And adverse effects of NSAIDs are inhibition of ovulation, risk of gastric ulceration, and cardiovascular disease risk. So this NSAIDs, whenever you are prescribing NSAIDs, you have to counsel the patient regarding all possible adverse effect, what is its effectiveness, and then you can give them the option. Another thing is with patient which is having deep pain, which is not responsible to, not responding to any medical management or sometimes surgical treatment also. In that case, you have to take help from chronic pain team. Okay, that is pain specialist. And in that case, you can use pain modulating drugs also like pregabalin or gabapentin or low dose amitriptyline. So these are the other alternative options for this chronic pain. Now, what are the hormonal therapies for this endometriosis related pain? Why these hormonal treatments will work with endometriosis? Because this is a disease which is associated with this cyclical ovarian activity. So what are the options of hormonal treatments are? It can be either combined OC pills, progestogens, anti-progestogens, GNRH analogs, or aromatase inhibitors. So these are the different options for hormonal treatment. Now, what Ishri recommends? What Ishri recommends for this pain is you can usually give empirical treatment with analgesics or hormones before a diagnosis of endometriosis is confirmed. But In that case, definitely the woman should be counseled thoroughly about the efficacy, adverse effects profile, and availability of different management options like laparoscopy, see and treat laparoscopy. Okay, so you have to counsel the patient before starting her on empirical treatment. Now, what are these different options of this hormonal treatment? So, regarding combined occipitals, usually these modern low dose occipitals are used for treatment of endometriosis related pain because they give other benefits also like contraceptive and also cycle control. So it will give the relief from dysmenorrhea. It will also provide this contraception and also cycle control. But when you compare the evidence, when you see the evidence, it doesn't have a strong evidence. It has very limited evidence for the efficacy of occipitals in treating endometriosis pain. And when you change this, like if you change the cyclical treatment to continuous treatment, the pain relief which will be improved. Okay, symptoms will be there will be more improvement in symptoms, but then adverse effect profile will also increase. So a moderate to severe adverse effects will be there with this continuous hormonal treatment, and it occurs in around 14% of women. And when you think of these terms, that is selective estrogen receptor modulators and selective progesterone receptor modulators, there is very insufficient evidence to support its use. So yes, you can use occipitals, but the evidence is somewhat limited. And another thing is when you usually the efficacy is more with continuous treatment, but also adverse effect profile increases with continuous treatment. Now, regarding progesterone and anti-progestogens. So, when you think of progestogen, the Cochrane review has concluded that medroxyprogesterone acetate, it is significantly more effective in reducing all symptoms. But can you see the dose here? The dose is 100 milligram daily. What we normally use for the patients, for even for this endometrial hyperplasia or for routine cycle control, it is hardly 10 to 20 milligram per day, and here they are using 100 milligram per day. So when you use such a high dose, definitely there will be significant adverse effect, and there are significantly more cases of acne and edema. So though it is useful with such a high dose, side effect profile will be also more. Then another progesterone which can be used is levonorgestrel IUS, that is Mirena. So Mirena also improves endometriosis related pain, and usually it is similar to that of GNRH analogs. Okay, so the pain relief is almost similar to that of GNRH analogs. But why this LNG-IUS is more better? Because it has a better adverse effect profile than GNRH analogs. So when you think of progesterone, LNG-IUS has a Yes. Am I audible? Am I audible?
Yes, ma'am.
Yes,
Yeah.
ma'am.
Okay.
Now you're
Sorry for
audible.
Yes, ma'am. Yeah.
that. Actually, the connection was lost in between for 2 minutes. Okay. So, till what you were able to hear? Till Danazol you were able to hear?
No, LNG iOS.
LNGIOS.
Okay. 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 So yes, LNGIUS, as I told you, it is better useful for this endometriosis related pain. Why? Because it is similarly effective as GNRH agonist in relieving the pain, and it has a better side effect profile than GNRH analogs. So LNGIUS will be a better option for endometriosis related pain other than medroxyprogesterone because we have to use it in high dose. Now, another progestogen which is used is danazole. Danazole is also effective in reducing this endometriotic pain, but here also the adverse effect profile is very severe. That means side effects are very common like acne, edema, vaginal spotting, weight gain, and muscle cramps. So danazole is also not routinely used. Another thing which is used is anti-progestogens. So anti-progestogens, they thought to exert their anti-proliferative effect on endometrium, but they will maintain the serum estrogen levels in early and mid follicular phase. So because of this maintaining estrogen levels, they will have a better adverse effect profile. So there will be no hypoestrogenism or no loss in bone mass. Okay, so the anti-progestin can be a good thing, but only thing is, the only anti-progestogen studied till now is gestrinone, and they have found it that it is a better thing as similar as progestogen with somewhat lesser side effects. Now, another thing which is used is GNRH analogs, gonadotrophin-releasing hormone agonist. So this is actually the best thing to use for endometriosis-related pain because they will provide us good symptom relief. But the only thing which precludes its use or which limits its use is their side effect profile. So this GNRH analogs is useful because of its hypoestrogenic state. Okay, so that will reduce exert endometrial atrophy and amenorrhea. Now, what Cochrane review says, GnRH agonists are more effective, but they are inferior to LNGIUS or danazole. Why? Because they have a worse side effect profile. So pain relief is almost similar to all this, but side effect is more with GnRH analogs. Now, what is the most important thing regarding the GnRH analogs is they will cause this loss of bone mass up to 13% at 6 months. So this was a recall question, remember well. So bone mass loss occurs up to 13% in 6 months use of GnRH analogs, but it is reversible with discontinuation of therapy. So to avoid this bone loss, simultaneous add-back therapy is recommended. Now, add-back therapy means what? You can use estrogen progesterone or you can use tibolone along with this GnRH analogs. Now, how this hormonal add-back therapy? So now you will think that when you add these hormones again to this GnRH analogs, they may also worsen endometriosis-related pain, but it will not happen. Why? Because the levels of estrogen which are needed to protect the bone and cognitive function, they are much lower. Okay, and so they do not cause endometriosis activation. They do not cause endometriosis activation, but yes, they definitely restore this other things, that is bone loss and other cognitive and menopausal symptoms. So you can use this add-back therapy along with GnRH analogs if you have to use it. Another thing which is used is aromatase inhibitors. So aromatase inhibitors most commonly used are letrozole and anastrozole. This letrozole and anastrozole adverse effects are hypoestrogenic and they include vaginal dryness, hot flushes, and bone loss. So because of their severe adverse effect, now this talk gives this sentence because they are giving this 2014 recommendation and they have said that according to 2014 recommendation, aromatase inhibitors should be only prescribed after all other options of medical or surgical treatment have been exhausted. Now, what is the recent change in 2018 history is you can use this aromatase inhibitors for deep infiltrating endometriosis. Okay, for DIE you can use where this medical or surgical management has not worked. you can use this letrozole or other aromatase inhibitors. Okay, so remember that thing, because that was also SBA. Here for deep endometriosis or deep infiltrating endometriosis, aromatase inhibitor is a management option for pain relief. Now coming to the surgical management of this endometriosis pain. So laparoscopy, it should be ideally performed at initial diagnostic laparoscopy. Okay, so what do you mean by this? So it should be a see and treat approach rather than a diagnostic laparoscopy. So whenever you are suspecting endometriosis, it is better to be prepared for operative laparoscopy rather than only diagnostic laparoscopy. So because as I told you, symptoms, they do not always correlate with the severity of the disease. Sometimes unexpected severe disease may be discovered at diagnostic laparoscopy, at initial laparoscopy, and sometimes it may require further referral, because sometimes it will be deep infiltrating or bowel or rectal endometriosis. In that case, advanced surgical expertise is required. So in that case, definitely a second look surgery is second look, or you have to refer her to the proper endometriotic multidisciplinary clinic for this surgical management. So indication for this laparoscopy, it should be individualized and it should include the woman choices. So whether the woman wants a definitive diagnosis of her condition, whether she wants the treatment for subfertility or investigation for subfertility, or she wants treatment for this severe disease like ovarian endometriomas or DIE. Also, it is important to note that response to hormonal therapy, it has not been always shown to predict the presence or absence. So when we think that if we give COCs and the pain is subsided, that means it is endometriotic pain, but it is not always the case. So when you want a definitive diagnosis, you should not rely on that. We have given the COCs and the pain is subsided means it is endometriosis. No. For definitive diagnosis, definitely you have to rely on laparoscopy. So what are the surgical options for this endometriotic pain? So one is definitely it is a laparoscopic approach should be used. So first, it is not a laparotomy, it should be a laparoscopic or minimally invasive approach should be used, because it is associated with less pain, shorter hospital stay, quicker recovery and better cosmesis. But sometimes laparotomy will be also necessary for advanced disease where there will be extensive adhesions or adjoining organ involvement is there. So sometimes in this case, open surgery is required. So what are the surgical procedures that you have to do? Sometimes is either excision, fulguration or laser ablation. Then excision and drainage or ablation of this endometriotic cyst, resection of rectovaginal nodules, adhesiolysis. So conservative surgery, it aims to treat all the visible endometriotic lesion and restore normal pelvic anatomy. So this should be the aim of the surgery for endometriosis. So the Cochrane review, what the Cochrane review says is, it is always better to do a operative laparoscopy than a diagnostic laparoscopy. So significant benefits at 6 to 12 months are there with operative laparoscopy than diagnostic laparoscopy or medical management. Now, when you do this operative laparoscopy, always a question is asked. So excision is always preferred. Excision of the lesion should be done and the tissue should be submitted for histological diagnosis, because histological diagnosis is required. Sometimes you may miss malignancy. Okay, sometimes rarely a malignancy will be there in this endometriotic tissue. So definitely to clear this diagnosis, histopathological diagnosis is required. So excision of the lesion rather than ablation is always preferred. But what they have given is ablation and excision is also, so ablation and excision both are equally effective for treating pain. So for mild endometriosis, it can be either ablation or excision. It will be effective for treatment of pain, but finally preferred approach is always excision. Okay. Now other other surgeries which are used for this pain, endometriotic pain is LUNA, that is laparoscopic uterosacral nerve ablation. According to HD, according to NICE, all guidelines, LUNA should not be done because it does not provide any additional benefit. Okay, so LUNA should not be done. Remember that. Now, another thing is presacral neurectomy. So it is associated with significant improvement of pain, but presacral neurectomy, it requires high degree of skill and it is associated with high risk of adverse effect like bleeding, constipation, urinary urgency. So it is seldom performed. So LUNA, there is no effect. Presacral neurectomy, it is effective, but it is rarely done. Other surgeries, so surgery for endometrioma. Now, till now, we were discussing for surgery for peritoneal endometriosis. Now we are discussing surgeries for endometrioma. So for endometrioma, when this endometrioma is more than or equal to 3 centimeter, always a laparoscopic excision is preferred. It is superior to drainage and coagulation because what happens is there will be increased risk of recurrence of dysmenorrhea, dyspareunia and pain. And also there is increased chances of recurrent surgery with this only drainage. So if you perform only drainage, there is increased risk of recurrent pain, dysmenorrhea, dyspareunia, and also increased risk of repeat surgeries. But the only advantage of drainage is because sometimes when you do this laparoscopic excision, so sometimes during the excision of endometrioma, sometimes there will be excessive resection of normal ovarian tissue also, and it will compromise the future fertility because they have found out that risk of ovarian failure after bilateral ovarian endometrioma cystectomy is 2.4%. So ovarian failure after bilateral endometrioma resection, it is 2.4%. So this is the only advantage of drainage, that it will not cause the resection of normal ovarian tissue. Now you have to also remember that these endometriomas, they are strongly associated with deep infiltrating endometriosis. So if you are suspecting DIE along with endometrioma, deep infiltrating endometriosis along with endometrioma, if you are suspecting, it is better to refer this patient to endometriosis specialized clinic, because there will be surgeons who are there will be expertise will be available for excision of this DIE also. So when you think of this surgery for DIE, that is deep infiltrating endometriosis, so the deep infiltrating endometriosis means it can involve uterosacral ligaments, pelvic side walls, rectovaginal septums, vagina, bowel, bladder, or ureter. So bowel endometriosis, it usually affects rectosigmoid colon, and it can be associated with bowel symptoms like bowel cramping, diarrhea, or dyschezia. Medical management, you can give medical management. It can suppress the pain, but it is not curative, and it is usually associated with significant adverse effect. And discontinuing this medical management, it usually results in recurrence of symptoms. So for symptom relief, you can give medical management of DIE, but it is not a curative. So how will you treat this DIE surgically? So for colorectal endometriosis, you can use superficial shaving, discoid resection, or segmental resection of involved bowel segment. Usually, most studies, they have reported improvement in pain outcome, quality of life, gynecological and digestive symptoms after surgery. But the complication rate is around 2.1% intraoperative, and post-operative complication rate is around 13%. Also, there is find out that there will be increased. Yes, any doubt? Yes, Akshata, any doubt? So there is increased recurrence rate after any colorectal endometriosis surgery also, and the recurrence rate after 2 years is around 5 to 25%. Now for bladder endometriosis, surgical treatment is usually excision of the lesion and closure of the bladder wall. Also, if it is involving ureter, you may require stenting of ureter or segmental resection, or sometimes end-to-end anastomosis and reimplantation if there are intrinsic lesions of the ureter or any significant obstruction of ureter because of this endometriotic nodules. Now, when this hysterectomy is required for endometriosis, so when you do hysterectomy for endometriosis, it will be TAH and BSO, because the basic pathology lies with this ovarian hormones. So it is not only hysterectomy, but you have to do BSO also along with hysterectomy if you are doing it for endometriosis. Now, so this TAH BSO, it is usually reserved for women with debilitating symptoms due to endometriosis who have completed childbearing and they are not responding to medical treatments. Now, if you conserve the ovaries at hysterectomy, there will be a 6-fold risk of recurrent pain and 8-fold increased risk of resurgery. So it is usually better to perform BSO along with hysterectomy. Also, hysterectomy, it is also used for to treat idiopathic dysmenorrhea and adenomyosis. Now, regarding the HRT after endometriosis, HRT guidelines, they suggest that you have to, once you do, yeah, I will tell you, Vijay. Where ISHRI guidelines, when you consider HRT, because for endometriosis, you have to perform this hysterectomy at earlier age also, very early age. So for that, ISHRI recommends HRT for hysterectomy. It should be estrogen plus progesterone or tibolone, because usually what happens, if you give estrogen only, it may cause reactivation of this endometriosis of other than the other sites than the uterus and ovaries. Okay, so to avoid this reactivation, the HRT should contain estrogen plus progesterone, or it can be tibolone till the age of natural menopause. So for HRT should be prescribed for this TAH BSO, and it should be estrogen plus progesterone. This is almost always asked question in AMQs on HRT. Now, there are some complementary therapies are also available, like Chinese herbal medicine, auricular acupuncture, transcutaneous electrical nerve stimulation. But whether they are useful or not, according to ISHRI, it should not be prescribed. Okay, according to ISHRI recent guidelines, they should not be prescribed. And even this talk also gives that it is necessary to do further studies and further RCTs to see the effectiveness of these treatments. Now, what about nutritional therapy or dietary modification? So it has been found that omega-3 fish oil or plus vitamin B12 supplementation and a diet high in vegetables and low in animal fats, it is associated with decreased pain, decreased endometriosis related pain. Also, intake of fruit and green vegetables, it is associated with decrease the risk of endometriosis, while intake of red meat increase the risk of endometriosis. There are some trials where they have given 2-month high dose of vitamin E and C therapy. It is associated with significant improvement in pain. Also, there are 2 other trials where they have also found out that there will be significant decreased pain when they have administered vitamin E, okay, for primary dysmenorrhea. Also, they have found out that the inverse association between endometriosis and BMI. So higher BMI is associated with more endometriosis, because might be because of this less estrogen resistance with low fat. Now, what is the role of these patient support groups and self-management? So they have found out that sometimes this mood disturbances, anxiety, high alexithymia, or multifunctioning OCD, these are more common with endometriotic patients, okay, endometriosis patient. So some women may benefit from the counselor or psychologist sessions. And this is the multidisciplinary team. This is the backbone of any RCOG or NHS. So multidisciplinary team is a cornerstone of management of endometriosis, where whenever you are suspecting any advanced endometriotic disease, they should be referred to the specialized endometriosis clinic, where there will be colorectal, urological, pain specialist and nurse members. They will be there. So this reflects that when the problems they are encountered with recurrent disease and recurrent pain, so they are solved with this multidisciplinary team, and there will be always chronic pain team should be there for management of this endometriosis related pain. So this is regarding this endometriosis talk. Yes, Bijoy, what was your question? Drug of choice for forced laparoscopic endometriosis surgery. Okay, you want to ask it for hysterectomy or for generalized laparoscopy? Just laparoscopy, no? So for laparoscopy, yes, they have, according to ISHRI, what they have given short-term management, it is not useful. Like COP, OC pills or this thing, they are not useful for short-term, but yes, definitely you can give for long-term. Okay, you can give for long-term pain relief. You can give these OC pills after surgery, but for 6 months, it is not useful. If you give just only for 6 months, they are not useful. Hope I am clear. Anything more? And aromatase inhibitors for deep infiltrating endometriosis even after surgery. Okay. Yeah. So this is the question. Type the answers in your chat box. What is the main advantage of drainage over ovarian cystectomy in the treatment of ovarian endometrioma, which is 4 centimeter and associated with dysmenorrhea and dyspareunia? So yes, your answer here. Yes. So answer is A. So drainage, there will be less ovarian reserve compromise, okay? Because you are not excising any normal ovarian tissues. Okay. Yes, Tabinda. So you are asking what is the, 1 minute. What was your question? What should be the first line treatment for endometriosis pain? Actually, it should be OC pills first and then LNG-IUS, okay? So LNG-IUS will be there for who have completed the family. Even but first it will start with OC pills and then it will be LNG-IUS. Okay. Next question. 38-year woman who has offered a total abdominal hysterectomy for with preservation of ovaries for treatment of endometriosis-associated chronic pain. What is the main disadvantages of leaving her ovaries behind? Yes. So here answer is D. She has 6-fold risk of developing recurrent pain and 8-fold risk of resurgery. So answer is D here. Yes, Kavita, if she's anxious to conceive NSAIDs, but here again NSAIDs, what happens is there will be inhibition of ovulation, okay? Follicle rupture will not be there. It will interfere with follicular rupture, NSAIDs. So it is also, it should not be given. NSAID should not be prescribed with ovulation induction or patient when the patient wants to conceive, at least during the ovulation period. So this is regarding today's talk. Now tomorrow we will discuss another talk. Thank you all of you for attending. Bye.
Thank you, ma'am. Bye.
Thank you, ma'am.